Good morning, everyone. Welcome to the SCCR Science Series. I'm Kiera Davis. I'm the Clinical Associate Director for Education and Training in SCCR. And we host these Science Series courses about every other month or so. We typically aim to do 4 to 6 of these a year on a therapeutic topic. And I had worked with Elaine on some informed consent things and asked her to join us on a topic that she is an expert in. And so that's why we have invited her today to talk to us about obstructive sleep apnea. Before I turn it over to her, I have just one announcement. So Elaine, sorry, I'm just going to share my slide really fast so people can see. We You guys can see my screen. Just give me a thumbs up. Okay, thanks. So we have a GCP workshop, Good Clinical Practice workshop, scheduled for Friday, August 22nd from 9 to 10:30. And the topic of this class is going to be Insights to Success, Lessons Learned from Audits and Monitoring Visits. So that's with Chris Anderberg, who is the Associate Director for Quality and Compliance in SCCR. And so she's going to talk to us really about things that we've seen and she's seen and her team has seen from audits and monitoring visits, so we can pass those lessons on to other learners, learn from, I don't like the term, but learn from some errors and mistakes and effort to avoid some of the common findings that are seen. And she'll talk about some best practices. We'll review, case studies. So I will put that registration in the chat. And you can also find that information on the SCCR website under Education and Training, under the offered trainings for GCP. And next, I'll introduce our speaker. So like I said, I worked with Elaine previously and asked her to join us for the Science Series. So Dr. Elaine Costa is a postdoctoral scholar here at Stanford in the Department of Otolaryngology. Her current research focuses on obstructive sleep apnea from diagnosis to evaluation of clinical outcomes post-surgical intervention. She earned her medical doctorate in Brazil. Is that right? Yes. And she holds a master's degree in sciences, where she specialized in otolaryngology. So she has foundational research experience from Brunel University London and has honed her clinical research, project management, analytical skills, and leadership in academia during her trainings over the last 12 years. So she is working here at Stanford. For how long are you going to be here?
I have 1 year and a half.
Okay. So a little while longer. So we are excited to have you. Thanks for joining us. Thanks for coming today. I'll be monitoring the chat. And one last reminder that if you are requesting Board of Registered Nursing credit, BRN credit for your continuing education units, please register in STARS for the class, because that's how your $35 stat funds are charged for the BRN credits. If you need help or are having difficulty finding that, just let me know. I'm happy to direct you. And you will also need to complete the evaluation for those credits, listing your name and your BRN number. If you have additional requests for CEUs, if for a professional organization like ACRP or SOCRA, please also list your name so I can get you your certificate. Okay, I will turn it over to Elaine now. And again, thanks for joining this morning.
Yeah, so good morning. Thank you so much for the opportunity to talk here with you. I'm going to present about obstructive sleep apnea from diagnosis to specifically cardiovascular outcome. For this presentation, I'm going to use this tool for interaction with you. So if you can please join. So first, let's get to know the audience. I know it's stats in general, but I would like to ask you, how would you rate your current knowledge of sleep apnea? Let me see the results here. basic awareness is the most people wise. The learning goals for today, we'll be discussing the clinical features and diagnostic criteria for obstructive sleep apnea. Then we recognize the pathophysiology, key risk factors, understand the diagnostic tools that we have and some methods that we use in clinical practice. Then we can assess the long-term cardiovascular risks, which is the main sort of mortality as we're gonna see, and then the range of treatment options available. This is a survey that was founded by the Sleep Society in the America, and nearly 1/3 of Americans diagnosed with sleep apnea. They are not currently being treated, which increase the burden of the disease. And it is a strong movement from the American Academy of Sleep Medicine to urge the policymakers and increase awareness of society regarding that condition and their outcomes for the impact that they have in the health of children, adolescents, and adults in the United States and then worldwide. Today we will focus on adult sleep apnea. So we have in our institution, the father of sleep medicine, that was Dr. William Dement. He was a strong advocate for this disease. And among many of his contributions, he trained the first generation of sleep specialists, founded the Stanford Disorders Clinic, that was the first in America, where sleep apnea started to be studied and diagnosed as a condition. And he helped to develop and popularize the EHI, there is the apnea hypopnea index. As we're going to see, there's a core metric in OSA diagnosis and severity classification. It is a global condition, highly prevalent, especially due to the pandemic of obesity. So those are the top 4 countries that has the highest prevalence rate. So we have China, USA, Brazil, and India. This map will show that globally that we have around 425 million people affected by the disease in the ages of 30 to 69 years old. This includes the map for moderate to severe sleep apnea, but we still have the mild range, and then those numbers increase significantly. To interact during the talk, we are gonna have a patient that we will follow up, and during this class, you will be his support network, and at each step, we're gonna advise him what to do during this journey. So we have Mr. J. He has 52 years old. He's a software engineer in the Bay Area. He loves doing hikes, and lately things are changing for him. So his partner is joking that he wakes, he kind of shakes and he snores. She noticed sometimes he goes silent in the sleep, kind of stop breathing. And he notes that during his daytime, he's not functioning really well. So he feels like tired, needs to drink some coffee to function during the day. And overall health, he's overweight and takes some pills for high blood pressure, but he's also worried because his dad had a heart attack at 55. So then, based on that, which signs were you most in his history? Stop breathing. Yeah, I'll give it just some seconds. Okay. Yeah, so the episodes of apnea when he stops breathing during the night is definitely something to start worrying about it. And then we advise him look for his doctor. The sleep apnea is a chronic disease. That's very important to highlight because we don't expect to provide a cure for the condition, but we do expect to provide control of symptoms. And it's a sleep disorder. We have multiple sleep disorders, so this is one of them. And participants, they will have multiple episodes of collapse of the airway during the sleep. That will lead to low oxygen saturation, and then body mechanisms will include a wake capsule, arousal, to compensate and restore the breathing. This leads to sleep fragmentation. So those recurrent, partial, or total outbreak collapse. We fragment the sleep with the consequence that we will see later. This image illustrates how the tongue can fall backwards during the sleep, especially in the supine position, which usually it's worse for the sleep apnea, and then the airway is blocked on the back. Get my point? So we can see here. So we have a blocked airway due to the tongue falling backwards, but also other soft tissues in this area of the upper airway can contribute to that obstruction. So it can be, sleep apnea can be either obstructive or central. Obstructive is the most common type. And basically, when you have that obstruction due to relaxation of the muscles and multiple other factors that we will see, we do have a respiratory effort. So there's muscles from the thoracic chest wall, they will respond to that and restore breathing. In central sleep apnea, you don't have that sort of compensation musculature. You just restore breathing normally due to central regulation for the breathing center. And it's a lot more rare. It's not that common. That's important to understand because when you have this sleep study that we will see later, we can have both episodes occurring in the same patient. But usually the obstructive episodes, they are way higher and more frequent than the central ones. So we still classify as an obstructive sleep apnea condition. The main risk factor is obesity due to increase not only of the general increase of the volume of soft tissues in the airway, but also the increase in tongue adipose tissue. So here we can see this forest plot analysis that was from a study that you can see that in OSA patients, the fat in the tongue is significantly higher than the OSA patients in this cohort. Male sex is also a risk factor. We have the influence of the hormones on this regulation of muscle activity and strength during the sleep, the relaxation. So women, the progesterone will have a protective effect in women before menopause. But after menopause and males in general, we do have an increase of obstructive sleep apnea. Hypothyroidism, we also have a relation to that regulations. Acromegaly is due to the anatomic increase in the tongue size, increased tonsillar and adenoid tissues. So this is a image that shows us an increased tonsil, and we have a classification that you probably know the Mallenpad score for that. So higher than Mallenpad, usually 3 or higher, we have increased risk for obstructive sleep apnea. And we also have anatomic conditions like craniofacial abnormalities. So patients with retrognathia that we can see in this picture, when this jaw is more backwards, this also decreases the airway space. So the pathophysiology is multifactorial. We could spend a long time talking about that. But just to highlight some of the mechanisms involved on the obstruction. So those collapse, the collapse of the airway, they can be due to unfavorable upper airway anatomy, either they will lead to reduce its pharyngeal caliber. Can also be due to decreased muscle activity. So we have fibers that are more resistant on the skeletal muscle and fibers that relax more. So normal people, normal individuals without sleep apnea, they will have a relaxation of the musculature when they sleep. It's just normal. But individuals with obstructive sleep apnea, this relaxation is increased, and that's why the obstruction occurs. The heightened upper airway resistance, impaired respiratory load compensation, variations in arousal threshold, so how sensitive is the patient to just wake up when the blood oxygen saturation goes low and the CO2 goes high. The loop gain, that's also a measure of ventilatory stability, and this critical closing pressure of the airway. So those are main points that are underlying the pathophysiology of OSA, and they relate to different phenotypes. So we will have the patient that is the obese patient. We can also have one that's more retrognathia, the ones that anatomy looks fine, but they have this dysregulation on arousal threshold and loop gain. So there are different types of OSA patients, and the discussion nowadays, as we will see later, is not more one size fits all for treatment and management. It's really a case-by-case evaluation. So a little bit of definitions. We have the respiratory events. That are the main events that we use to define the condition. So the American Academy of Sleep Medicine will define hypopneas as a reduction in the airflow, the flow of oxygen through the nostrils. That is this reduction equal or above 30% from the baseline that's been recorded during the sleep study for at least 10 seconds. And then this drop in SpO2 has to be associated with the decreasing in the airflow. The drop in the SpO2 can be of 3% or more than the baseline of SpO2 for that patient, or it can be 4%. And those are just criteria that insurance reviews and studies reviews as well. We see nowadays that the 4% criteria is the one that is most associated with those clinical cardiovascular outcomes. So those are usually the ones we use to look for, but we have more. Also, it can be the desaturation associated with the decreasing of the airflow or anaerosal. So if you have this decreased airflow and desaturation, it counts as hypopnea. If you have the decrease in airflow or anaerosal, this patient waking up, and we can see by the EEG monitoring, it also counts. And the apnea events is when there is a total cessation of that airflow for 10 seconds as well. We have another definition that is the respiratory effort-related arousal, the RERAS. Those RERAS, they are an event that does not lead to desaturation. So it's not, it's a reduction in airflow, but it's not long enough, less than 10%. Does not lead to desaturation, but it still leads to arousal. So it does contribute to the sleep fragmentation, disrupting sleep cycles and disrupting sleep quality. So that's some reports will have that as well. If you have any questions, please feel free to open the mic and ask, and I will try to make things clear if needed. If not, I'll keep going. So what are the symptoms? We have, those are main symptoms of the condition. So we can have the snoring, loud and irregular. People, not everyone will have every single symptom. So if you are oligosymptomatic, but you can still have the condition. It's individual. It's a case by case. But you can also have daytime sleepiness, unrefreshed sleep, regardless of that sleep duration. So some people feel tired, but I slept 10 hours, but I still feel tired. Maybe some disorders happening during that sleep. It's not only about the duration. Increased fatigue when patient is sedentary, nocturia, increased frequency going to urinate during the night, choking and gasping in sleep, dry mouth or awakening, morning headaches, obesity, as we saw, our pharynx crowded, and increased neck circumference. Those are also signs and symptoms that are associated with the disease. So either participant will refer to the provider, will experience that, or it will be identified in the clinical physical exam. So how to evaluate them? There is a screening tools, questionnaires. There is the stop bank. The stop bank, it will have a mix of objective measurements and also subjective. So we ask if the patient stop breathing, if they have a loud snoring, but we also count in that score the value of the BMI, if it is the sex, if it is male or female, and those kind of things. This has a sensitivity that varies according to the population, so depends on the severity of the OSA, where the sensitivity was calculated, it does vary. So it varies from 80 to 93%, and also specificity is pretty low. And the Berlin questionnaires, they have three categories. So the category of snoring and witnessed apneas, daytime sleepiness, and the presence of hypertension and obesity. Patient has to be positive for at least two categories to be considered as potentially having sleep apnea. The sensitivity and specificity is also moderate. The Epworth Sleep Scale, it's not a tool to be used for screening purpose alone. It investigates excessive daytime sleepiness. So helps the provider understand how sleepy, how drowsy is the patient during the day. So basically, there's a few questions that ask how likely are you to doze during a few activities, just like sitting and watch TV, and the patient will scale. I will never doze, I'll moderate chance to doze, light chance to high chance to doze. And then if the score is equal above 10, we consider as having excessive daytime sleepiness. Sensitivity and specificity is also varied, and we have multiple other questionnaires that we use to try to measure that symptoms that are subjective, such as fatigue, insomnia severity scale, but those are all subjective, and it helps to add information about the symptoms, but none of them can be used for the sake of diagnosing the condition itself, as you probably know. And those questionnaires is the ones that when some studies, they related the PROMS, PROMS, that are patient-related outcome measures, they are referring to those questionnaires. So basically, their intervention help how the patient is feeling regarding their condition, yes or no. So the American Academy of Sleep Medicine has their clinical practice guideline, and a few recommendations will be popping up during this presentation. So they recommend that clinical tools, questionnaires, and those prediction algorithms, they cannot be used for diagnosis of OSA in adults in the absence of the objective test that is the sleep test that we see later. So this is strong evidence. So now I'm gonna hear for you, what would you tell Mr. J to do first? After we have been exploring his symptoms, let's see if we come with some answers here. Okay. A few more minutes. So it seems like everyone is going with the first option. So yeah, let's schedule an appointment with him. We don't want to delay his diagnosis. So yeah, how do I know that I have OSA? We have the objective measurement, that is the sleep study, and all its synonyms in the formal synonyms or the public, what they know about it. So it can be polysomnography, sleep test, sleep study, watch pad, in lab, home sleep test, overnight sleep study. So those all means more or less the same, because we have 4 types. So those types, this is the classical division for that. The type 1 is the gold standard of a start, is the polysomnography, the overnight sleep study. So you go to the sleep clinic, you need to have access to that. So this a barrier for that performance is the access to healthcare in underserved areas or underserved populations that we are trying to overcome with new technologies. But this is the gold standard. It's the one that gives us more information about the sleep of our patient, because we will monitor for EEG, EOG, EMG, so electroencephalogram, electrooculagram. We can see the movements of eyes, the muscle activity in the chin, electrocardiogram, airflow, respiratory effort, oxygen saturation, body position, and limb movements. So those wires and monitors will be oversight with a sleep technician. So when you do in the lab, we have a controlled environment. This is indicated for patients who has comorbidities that we will see later. And also they don't have that much strong suspicion about the sleep apnea. It's not that sure. So this will give more granulated and detailed data to have a conclusion about that. And also you can observe other disorders, not only obstructive sleep apnea in that. So for example, a patient that has restless leg syndrome, so periodic limbs movements that are excessive, and sometimes that's what's disrupting the sleep. It can be seen there as well. This type of study can have special protocols. So the split night is when you need to a CPAP titration. So sometimes you can go for the study just for diagnosis, you just sleep the entire night. You can go just for CPAP titration, so you go and sleep with a CPAP machine and they regulate test different pressures to see which one is ideal for you. But you can also do the split. So the split is basically start sleeping as a diagnostic, just sleeping with that monitoring. And at some point in the night, if your EHI goes really high, which means if you're having a lot of events of like obstructive sleep apnea, you will just receive a machine and sleep the rest of the night with the CPAP, and then different pressures will again be tested. There is the multiple sleep latency test and the maintenance of wakefulness test. You could go beyond the night. So patients who have very excessive daytime sleepiness, sometimes it disturbs with their professional and working capacity and can be dangerous, like if they are a driver. So how do you measure that? You can do this sleep study, then you stay during the day as well, being monitored for that. So again, a guideline from the current guideline will suggest that if clinically appropriate, the split night diagnostic protocol, other than the full night, can be used. This is just a suggestion, it's a weak evidence. You can do just some diagnostic, but if it's suggested that if appropriate, you do a split night. So you do both at the same time. This helps to optimize healthcare usage. Otherwise, you would have two sleep studies, one for diagnosis and another for CPAP titration. And also, they suggest that if the initial polysomnogram is negative, but you still have a suspicion for OSA, you repeat that, because we have a night-to-night variability that we see in our practice. So one night you can sleep very well, but other not. And how do we really know if you just had a bad night or that's your normal? Is by monitoring multiple nights. So you can repeat that. The type 2 is the same as the type 1. The only difference that you do at home, but you don't have a technician with you. So the cons of that, the con is that you probably, if you lose some connection with some sort of wire, you won't be able to fix and you lose data. So we don't see a lot of that. The home sleep apnea test, the HSAT, is very popular. So it's what we call the home test. It's a portable, it's unattended as well, but typically records for only 4 channels. So you have airflow, respiratory effort, oxygen saturation, and the heart rate. It's usually for patients who have a high probability of having sleep apnea. So symptomatic patients have a lot of risk factors, just fit the most of average type of the patient that has sleep apnea. It doesn't have a lot of comorbidities, then they just can go home. Of course, if the test is negative and the suspicion is maintained, they will go to the in-lab sleep study, the type 1. And the type 4 is very limited. It's only oxygen and airflow and heart rate or heart rate, just 2 channels. We don't usually have it for diagnostic tools. You can use it for monitoring purpose after treatment is started. So just a recap, in-lab versus at home. You can have advantages of the in-lab. It's more accurate, you have more information, you can detect other sleep disorders, patients observed. It's more expensive, you have limited access, and may disrupt your sleep schedule because you're sleeping in a strange environment. For the home sleep test, it's better. Advantages is that it's less expensive, it's more convenient, can be performed at home, it's less intrusive and more comfortable. But the disadvantage doesn't measure everything and is more likely to have some inaccurate results. due to setup. So your guideline, it comes again, that is recommended that sleep apnea testing with adequate device for diagnosis in uncomplicated adult patients present with signs and symptoms that indicate high risk to moderate severe. So home sleep test is a patient that doesn't have comorbidities and a high probability of having the disease. If negative, we repeat, and the polysomnography in the lab is for the participants with significant cardiorespiratory disease, potential respiratory muscle weaknesses, awake hypoventilation, or suspicion of other conditions as well. This is just an example of a polysonogram that's we see on the report of the polysonography. We don't expect to fully learn how to interpret these in this class, but just for you to have an idea how the report comes. So we will have the data from the multiple channels grouped together, and then we will analyze it to see where the events are. So in an episode of desaturation, we will usually be associated with change in all of those parameters. And it also have, we cannot see here, but usually the report comes with the body position. So you can see if most of episodes came on the supine position, on the lateral position, how was that? Some patients, they do have only in supine, and if they just want to change body positions, positional therapy is one alternative as well. So severity classification, so far in the guideline, the standard is for us to have the EHI. EHI is the apnea hypopnea index. So we basically make a calculation of the frequency of those events. So we sum the apneas with the hypopneas, and we divide that for the sleep hours. This index, when it is below 5, it's normal. So it can happen that a patient has a snore and an EHI below 5. In that case, we call it primary snore. It does not, some insurance would approve some sorts of therapy or not, but basically it's a snore due to a very partial collapse. So it's not a complete collapse, it's just like a relaxation that vibrates the structures on the airway, the soft tissues, and then you snore, but doesn't lead to obstruction at all. The EHI 5 to 15 is considered mild, 15 to 30 moderate, and above 30 severe. There is another index that's sometimes reported. When I say that the reporting varies, is because it really changes according to the company that provides the software of the sleep studies. So we have multiple variables and parameters, but we don't have all of them in every single report. It's just the standard. But some of them we report the RDI, the respiratory disturbance index, is basically the rarest that we saw before, the events that doesn't lead to desaturation, but does lead to arousal, and it's just a reduction in airflow below 10 seconds, so it included in this count. And EHI and RDI that can vary significantly, so there is no correlation really. New metrics, there are reported usually that is related to the hypoxemia in general. They are usually more correlated. New studies show that they have better correlation with cardiovascular outcomes than the EHI alone. So the main one is the oxygen saturation index, the time that the patient spent below 90%, and the hypoxemic burden, which is now increasing awareness, is being more talked about. So what is hypoxemic burden? You have the saturation curve, and when you have a curve that is under the threshold associated with an event, either apnea or hypopnea, you basically sum the area under the curve for all those desaturations events that was associated with either hypopnea or apnea, and then we have a sum of that area under the curve. It is being shown to correlate better with the clinical outcomes. So the American Academy of Sleep Medicine is currently working in updating the diagnostic protocol, so we don't have the results yet, but probably will come sometime soon. To add those new metrics to the severity suggest they will be reported and used for the severity classification. So far, we classify by EHI only. So it's mild, moderate, and severe. So let's wait for the new guidelines to see what it will come. So if you wanna answer this now, we are asking, okay, so Mr. J went to office following your advice, and the doctor offered him 2 ways of assessing doing the sleep study. So which one would you? Okay, so I see some answers coming up. Let's wait. So we had most of them going with the second options. So we take a small kid home and do the home sleep test, which I agree. So Mr. J has only hypertension, not a lot of comorbidities, a lot of symptoms. So first we go for the home sleep test. Another thing that's nowadays really coming up is the consumer wrist-worn sleep trackers, and comparing to the polysomnography. So we see increasingly patients coming due to the numbers on their device. So, okay, I didn't achieve the 100 score for my sleep, or I didn't got enough deep sleep according to what the device tells that is a deep sleep. And there is a term that is called orthosomnia, which is the anxiety generated by that tracking. So do I have a problem because my device says so? This new meta-analysis just this year analyzed 24 studies and 12 devices. Those were wrist-worn devices only. And basically, it shows that they are less accurate than the polysomnography in key parameters like total sleep time, sleep efficiency, and sleep latency. So when compared to the gold standard, they don't perform as well as the sleep study. Therefore, it is still useful for tracking. Just the academy raise awareness to not take them as a true value. So we do need to confirm with the sleep study, but it's very useful for screening and for increasing alert. So the Apple, for example, they have an alert for the sleep apnea. The Samsung's working as well in a device for that. So just be aware of that. The ring, the Oura Ring, had a little bit better correlation with the sleep study, but those devices, they are very helpful when we think about increasing access to diagnostic tools, not really diagnostic, but screening tools and for sleep apnea, when patients cannot go to the sleep center easily. So just coming a little bit back to our patient, he has an EHI for his home sleep test of 25. And this, what does that mean? Okay, so this is easy to understand. It is a moderate sleep apnea, and these are the ones. See some answers coming up. Okay. So most of them was the last option. It is a form of sleep apnea that can raise blood pressure, acid accident, and heart risk. We will see later, but yes, that's true. So it is a moderate sleep apnea, and moderate to severe are the ones that are more correlated with those clinical outcomes. So OSA has a range of impact on the clinical endpoints, as I said. So we will have the pathophysiology that will lead to intermittent hypoxemia and other physiologic alterations. But what's the clinical endpoint of that? Will be some sort of disease. Cardiovascular, most of them has very strong causal association. So we have association that was already shown in the studies with hypertension, coronary heart disease, arrhythmia, heart failure, and stroke, considering a cardiocerebrovascular consequence. We also have the metabolic dysregulation, so diabetes and metabolic syndrome is correlated with obstructive sleep apnea as well. And in that sense, we can have an overlap of what comes from the effect of sleep apnea itself and what comes from obesity on obese patients. Not every patient with OSA is obese, though, so 20 to 40% of OSA patients are not obese. But in those who are, both factors can interplay their roles. There are also other consequences like cognitive impairment, neurovascular dementia, and Alzheimer's being associated with sleep apnea, and some sort of cancers. But cardiovascular risk is the one that we are going to address today. So as I was saying, is proven to be modifiable cardiovascular risk. We must pay attention to that. Potential etiological risk factors for that sleep apnea and those consequences. So just as a recap, can have the respiratory control and stability, like the central disturb in sleep apnea. We can have the obesity as a main factor, and the upper airway dysfunction in general, the anatomy factors, and also the muscle response to the control during sleep. Those relate to the sleep apnea. Then we can have this increased sympathetic nerve activity. We can have the metabolic dysregulation, a chronic inflammation, so we do increase oxidative stress as well, vascular endothelial dysfunction, and intermittent hypoxemia. So all those factors, they will play roles together. And then leads to the conditions. In cardiovascular disease, can have atrial fibrillation, hypertension, and heart disease. Atrial fibrillation will be correlated with sudden death. So we can have arrhythmic events that can lead to that, and we need to be aware. So what we can do about it then? I'll just ask to the audience, what you would suggest this patient to do as a means of treatment, considering that he has a moderate obstructive sleep apnea that leads to increased risk of cardiovascular outcomes, accidents. Let's give a few minutes for people to answer. Okay. So let's see here. Most of them are going with the first and third option. So yes, first the CPAP and third weight loss. We will see, we start discussing about therapies in a second. And as I mentioned before, nowadays we don't want to talk about one size fits all. So we will continue to have, for now, this PEP, which is the positive airway pressure, the mask, as the gold standard. But we do have all sort of therapies that can be adjuvant. So we can have a combination of those according to patient preferences and provide the indications. So it will really be based on a conversation and what is your preference and what can benefit you, considering your OSA phenotype and who are the patient, right? So those are the options. We have a few options, not all of them. So we do have the positive airway pressure, the non-surgical option, so weight loss, as you answer, like weight loss for obese patients, of course, that will encompass our lifestyle changes and the bariatric programs, which can go through a medication, trying therapy first, but can also go to surgery. So bariatric surgery as a means of reducing weight and improving sleep apnea is also an option. The oral appliance therapy. So we have some mandibular advancement device that I will show a picture later. The idea behind treatment, understanding treatment, is understand what is the goal is. So according to the phenotype, if it's anatomic factor, the goal is to increase the airway space that's narrowed. So all the mechanics of those devices will target increasing the airway space. If it is some sort of central disturbance, then or regulation, we can see medications or what's kind of stuff. The positional therapy, as I mentioned before, if the patient has nearly all the events during the supine position, then we can change positions. And we have pillows that will make the patient sleep more on their side than on their back. And very like rudimentary alternatives would be to had a tennis ball and just tape it on the back. So when you go back, if you hurt and you don't sleep in that position. But nowadays it's not used. You do have special pillows that you can either in your back or in your front, so you just don't fall back during the night. Medicines. So we will see the only one approved so far is the GLP-1s, Zepbound, that is for weight loss and sleep apnea. It was approved for, we will see later. The AD109 was not approved yet, but clinical trial phase 3 had good results. So they will probably be applying for that approval soon. Surgical treatments, we have also a big range of options. I will cover a few today that we will have understand later. This paper and this image is an MRI image to help you understand the effects of the weight loss on sleep apnea. So we can see here the hypersignal in white in the tongue. It shows fat in general for this patient before weight loss surgery, and the AHI 18. After surgery, we can see a reduction on that fat signal in his tongue. And also, you can observe a slight increase in the black airway column right here, as you can see. So one thing to be aware of the obesity and the tongue fat, but also the fat in the tissues around the upper airway, is that the fat distribution in the body varies between patients, right? So we can have an obese patient that doesn't have sleep apnea, and the opposite, just because the accumulation of the fat is different. And we don't understand yet what determines the accumulation of fat specifically in the tongue. And we also don't have a means of removing the fat specifically from the tongue and upper airway. So yes, when you think about weight loss, just general weight loss, and most of the individuals will respond. But of course, where the fat is varies. So positive airway pressure, the gold standard, is the first line therapy. Is the one we have most studies showing reduction on AHI and clinical benefits as well. We have 3 types of the machines. It can be continuous, that is the CPAP. So you offer constant air pressure through your mouth and or nose. So we can have a full mask, we can have only nose mask. Nowadays, we tend to use the nose-only mask, so the nasal mask, just because we don't need air to go into the stomachs, and it's just effective as keeping the airway open with pressure. We have the B level. Sorry, there is this B level, not B level. So this machine is like a CPAP, but it will deliver the pressure based on whether inhaling or exhaling. So it's not one unique and continuous pressure. The pressure varies in inspiration and expiration. And there is the auto-adjusting PAP. So the machine itself automatically adjusts the pressure with inspiration and expiration. It's always important to work together with the therapy that will help to check the mask feed and the right pressure for you. And that's why we have the titration studies as well to help with that. Side effects of the therapy, we can have congestion, dry eyes or mouth, nosebleeds, runny nose, and the stomach discomfort or bloating. Nowadays, we don't expect that as much with the nasal mask, but if you do have, you have to talk to your provider. And if you have any questions of PAP, please feel free to stop and I'll be happy to take them. For the medicines, so we only have one drug. There is a Zepbound. It is a Tide, which is one of GLP-1 drugs. It was approved by FDA in last December, and the population is adults with obesity and moderate to severe OSA. To be used for a better effect, it's advised that it was approved to be used with adjuvant therapies, so reduced calorie diet and exercise. We see that with those weight loss therapies, if you cannot stop this medication, so if you for a longer time, or you are at risk of regaining weight and then you regain the symptoms, so you have to work closely with your provider to see. But the results are starting to be promising. So the mechanism is a dual GLP-1 and GIP agonist, so it drives substantial weight loss on the patients. The key trial result that led to the approval, we had 469 patients during a time of 42 weeks that showed a reduction in 50 to 60% in the EHI that was significant, and also associated weight reduction. Safety notes from the drugs, gastrointestinal issues, and also having encounters with patients with pancreatitis, gallstones, hypoglycemia, retinopathy, and suicidality. So this requires close clinical monitoring as many other drugs. So this new molecule that is not yet approved, doesn't have a name. They call it AD109, which is designed to target the neurological control and activation of the upper airway dilator muscles. So we saw a picture in the first slides about the extrinsic muscles of the airway. So those dilator muscles that keeps the airway open, they are being targeted in this therapy to not relax too much during the night, so they keep some sort of patterns of the airway. So it combines two substances, the aroxybutynin and atomexin. So they are antimuscarinic and selective norepinephrine reuptake inhibitor. So it will increase the chemicals necessary to keep the airway open and stimulate the muscles. The results from the phase 3 clinical trial, which was just released in May, and this slide they provided is promising. So we have disease control. So EHI 4%, that is the one that we use to evaluate this clinical cardiovascular outcomes, just because it didn't show better correlation. It was reduced in controlling for 23% of patients, as we can see, considering it was only 1 month of therapy. So 50% with mild OSA, the baseline achieved disease control, 56% had improvement of severity, so reduced the EHI significantly, and same with those here. So the oral device, we have multiple. We have to work with an orthodontic teams just to see which one is suitable for you according to your skeletal structure. So you can do either X-ray or CT scans to make the measurements necessary to understand how much advancement it will be needed to bring the jaw forward and then increase the patterns of the upper airway. So we see here an example. So we have a device and a control here that they can just adjust how many millimeters do you need to gain in your airway space in order to improve that. This is one example, and we will have multiple. Mouth taping, it seems like to be a social media trend, and usually mild OSA, so even the oral devices, the therapies are more for mild OSAs and mouth breathers, in this case of the mouth tape. So it can be an adjunct treatment to the device, which is the oral appliance, also called mandibular advancement device. And it can also prevent CPAP or bilevel mouth leaks. So patients who have the nasal mask, but then they are mouth breathers and they have some leak on their mouth. So maybe the idea is, would that help? We still need much more studies to be able to make a conclusion on that. We had this systematic review that was published recently this year, and it was 10 studies. 2 studies where only 2 showed that was an improvement statistically significant in the EHI and or oxygen desaturations. The other 8 studies showed no difference in those metrics, and they highlighted potential risks of aspiration in the presence of nasal obstruction, but it's not clear and we cannot make a final opinion on that. But further studies and robust studies, they definitely need to be done to elucidate those benefits. So those are the 2 studies that showed benefit improvement in the EHI. And those are very prospective small pilot studies with N of 30 patients, one of them, for example. So when they look at the PROMs that we mentioned, the PROMS, the patient-related outcome measures, the Epworth Sleepiness Scale, which is the daytime sleepiness, improved on 1 study only. And they had also the visual analog scale, like the pain scale, but for snoring, that only 1 study also showed some sort of benefit. So myofunctional therapy is an option also for mild case or primary snoring case, people who has EHI below 5 or between 5 and 15. So it's basically the orofacial exercise. We can see some sort of improvement with those exercises, but the main problem would be this similar to CPAP therapy, which is compliance. So CPAP therapy seems awesome, but if you comply with that, and compliance would be used at least 4 hours every night, at least 4 hours to have a clinical benefit, a sustained use. And patients who comply with CPAP, they have great outcomes. The issue is not everyone, and most of them don't comply. And then they come asking for alternatives. So I don't want to wear the mask. What can I do? But the same with exercise. Can you exercise every day? Imagine going to the gym. Some people maybe can try and improve the muscle tone and that therefore improve the patterns of the area somehow. But again, those therapies can be adjuvant and they can be combined, but there's no evidence of they standing alone will solve that. Surgical procedures, so that's more my area. We have multiple procedures for sleep apnea, and I will go through the main ones. So before that, we have to evaluate where the obstruction site is. So basically what I'm gonna operate. So which tissue I'm gonna remove or change anatomy to improve the area, right? So the sleep study doesn't provide that information for us. It just gives the position of the body, it gives the measurements of oxygen saturation, the frequency of sleep apnea and hypopnea episodes, but not where the obstruction lies itself. So we do need some imaging studies. CT, MRI, those static image studies, they are not ideal, but some studies would try to look on them, but we don't usually use on clinical practice if it is soft tissue surgery. Unless we need to do a skeletal surgery, we must have a CT scan to look at the osseous skeletal structure and make the calculations to what I'm going to advance there. So we do have the dynamic imaging studies. There is the nasal laryngoscopy and the drug-induced sleep laryngoscopy. So both of them, you have the scope that we insert through the nostril, and we do some, if it is nasal laryngoscopy awake in the office, we do local anesthesia, and then we can see in the camera, the patient can see at the same time as well, the image. So we can look through the nasal cavity and search up and down there here what seems to be the constriction and obstruction site, if any. The drug-induced sleep endoscopy, we use the same device, so it's sort of a similar procedure. However, we patient undergo general anesthesia, so in the operating room, so surgical center, we do some induced anesthesia to mimic the sleep, just to make the patients sleepy and able to snore, and we try to assess the obstruction site, and then we monitor that. During the sleep endoscopy, so we are mimicking the sleep, and we can see more physiological than a patient sitting on the office and just having a scope in their nose. In the surgical room, they are laying down, and we can assess better. We do have assessment for the drug and sleep endoscopy of 4 main obstruction sites. That would be the velum upper here, the oropharynx, the area up below the palate, and the base of the tongue, so the area behind the tongue, and epiglottis, to see how sometimes the epiglottis is very flexible and it keeps falling, and therefore blocking the airway right here. So we try to see what's going on with that patient. To define surgery, it's really important as well to look at the partner of the obstruction, the pattern. So in the velum, some patients can have a normal airway. That's the view that we have. So we are going from up to down. We see this dark is the airway space. Some patients will have this collapse. So instead of having it opening during normal breathing or sleeping, they will have a concentric collapses. It is when all the walls, they collapse. So the lateral walls and the anterior and posterior walls, they will collapse altogether. Some patients, they will have the partner of collapse that's lateral, so only lateral walls collapsing. Some patients will have a partner of anterior-posterior collapse. And that will help us understand where the problem lies. So it's anterior, just like the palate, is something that we can think about. If it's lateral, we have the tonsils on the lateral, and those are the main thought process, basically. So for palate surgery, we can perform the tonsillectomy. So tonsillectomies, we will remove these lymphatic tissue pads that we can see here. It's normal to have. When it is very enlarged, we can remove that. And some patients, we can perform the simple tonsillectomy. The most common from the palate surgeries, and also the one who has the higher correlation of those clinical cardiovascular outcomes, is the uvulopalato-pharyngoplasty or U-triple-P. So the U-triple-P, I don't have a picture, but going back here, you can sometimes remove the tonsil at the same time, and you do a surgery on the palate. So basically, let's say a plastic surgery on the palate to reduce sometimes the size of the tonsil, and to make, with tonsillectomy, just push those tissues forward and increase that space as well, and bring it forward. There is a radiofrequency that we can perform. The radiofrequency procedures, it's a needle-like instrument that is inserted in the tissue, that it can be any soft tissue, it can be palate. If it was a nasal procedure, it could be the turbinates in the nasal, the nostrils. And then the energy will be transmitted and cause a controlled damage. So they will, by the healing process, there will be a scar of that tissue, and that will have a retraction. It can be performed in office under local anesthesia. It takes about 10 minutes, but sometimes you need multiple sessions to obtain a result, and the sustained result sometimes not necessary and not satisfactory. So from the soft tissue surgery, the most popular is the U-triple-P, and this is the one that is better correlated with the clinical cardiovascular outcomes as well. The skeletal surgery, we have the maxillomandibular advancement surgery. In this case, we will do, it's also called orthognathic surgery. So we will basically have the CT scan, we do a surgical planning and see how much is needed to advance the skeleton in order to improve the airway. It can have, of course, the risks of the surgery. So there is a high risk of nerve damage, because we have the nervous really in the structures close here. We can have, sometimes we need to do nasal surgery after procedure, because as you move that part, you can have septum desviation sometimes. And it also alters their facial aesthetics. The patient will look different after that. And that's something that they also need to be fine with, that change in the appearance. Most of them do. The upper airway stimulation, right now, the only one that is the only company that performs that is called Inspire. It was approved by FDA in 2014 in the US, and it consists on a neurostimulator that we can compare to a pacemaker somehow. So we have this device implanted in your chest, and then you have the leads, the stimulation leads that goes to the hypoglossal nerve, and then the sensing lead that will have fourth intercostal region. During the sleep, patient has a control, and then after adjusting the setting, it will be the voltage will increase with time in the post-op. So after 30 days, they have the activation of the device. So when its healing is okay, no surgical complications, then we start stimulating. And basically, you start with a low voltage, and the goal of the therapy is to find the right voltage where the tongue is being stimulated. The muscle tongues will respond to that stimulation, pulling backwards. So the stimulation cannot be that strong to the point of waking the patient up and disturbing his sleep, but has to be just enough to open the airway. So pulling the tongue forward by electric nerve stimulation will increase the upper airway. That's the goal. New devices are developed. We're developing that being under FDA approval, but not yet approval, that they will be less invasive, but still the same idea of strengthening and pulling the tongue forward for them. Other surgeries, we do have the principle of then thinking about the treatment, anatomy, where the obstruction lies, and if there is a site that I can target to increase that airway patterns. The nasal surgery, in case of nasal obstruction, they are not recommended as a procedure for the treatment of obstructive sleep apnea. They can be done in combination with other procedures, or if they are performed as a standalone surgery, it's to help with CPAP compliance. So the research does not show benefits on sleep apnea, on AHI reduction, and other parameters for nasal surgery alone. It doesn't happen. But it does help with patients adhering better to CPAP, so we have less resistance in the nasal flow with after surgery due to less obstruction. So it feels more comfortable and patients feel better with that. So nasal surgery is either to help with CPAP compliance or to be in combination with other procedures for sleep apnea. And then some patients has a big tonsil, lingual tonsils back in the back of the tongue, and they can undergo that resection as well, partial glossectomy. Nowadays, we don't see a lot of those tongue surgeries, but they exist and they are alternatives, among others. This study from our team looked at IBM market scan research database between 2007 and 2015, between adults with OSA. So in the database with 4 million, around 5 million patients, they identify 80,000 that underwent surgery, 1 million untreated, and there are around 800 CPAP patients. So after adjusting models like propensity score matching and the statistical models to balance those three groups, they observed the overall estimate expenditure, the costs of healthcare utilization after those therapies. So the gray line is the cost of healthcare utilization with surgery. The orange line is non-treated patients, and the blue line is the CPAP case. So we see that during the figure A is the procedure itself. So during the treatment time, surgery is more expensive. But then in the follow-up, the years after, patients who underwent surgery, they become less users of the healthcare system. So although more expensive for the procedure itself, during a long-term follow-up, so patients, they can have less overall healthcare utilization compared to the non-treated and CPAP patients. So it's just looking at trends of healthcare costs in general. And here you can also have a picture of that trend. So considering the different variables of monthly pharmaceutical payments, outpatients payments. So surgical patients in the long time, they have less utilization and costs in general. So yeah, I will finish with the summary of our management for OSA. So today we are able to have a general understanding of what the condition is, what is involved in risk factors, diagnosis itself, and the importance of that because the burden it offers and is proven to be associated with cardiovascular health disease. So how do we then identify those cases and we treat, since it is a modifiable risk factor for cardiovascular conditions, right? So first, we have either the clinical suspicion, so patient with symptoms, or they have a rising risk. So they have some conditions associated with obstructive sleep apnea, but they might not have symptoms. But since those conditions are associated, we want to screen and investigate, screen for sleep apnea. So in those cases, we will check if they have some active comorbidity that's cardiopulmonary, like congestive heart failure, stroke, hyperventilation, use of opioids, or poor sleep. If they do have, we go through the in-lab sleep study, in the polysomnography type 1, as we saw. If they don't have, we can do the home sleep test. In the both sleep in lab and home sleep test, if we have mild sleep apnea, so the EHI or the respiratory event index above 5 and have symptoms, we treat. If they have above 15, so moderate to severe case, even if they don't have symptoms, even if they don't complain, we treat because we see there is a higher correlation with cardiovascular disease. If the home sleep test is normal, EHI below 5, but you still have a high suspicion, you go through the in-lab sleep study and then assess likewise. In case it is negative, we saw by a weak recommendation by the guidelines that you can repeat, just because we understand there is a night-to-night variability in the sleep of every single individual. When we come to treat, at least we initiate with the CPAP, and then we see like the better adjustment of that CPAP. Also, insurance we request that you try the CPAP. Even though I don't like it, but you have to try and prove that you were not compliant or was not a good fit for you. So we have to try and maximize this therapy effect. Moderate to severe cases, we will always treat. And then if patient has some difficulty with the CPAP, you should discuss this with the sleep specialist, other therapies. Nowadays, we have a range options of therapies, and it should be discussed in a case-by-case basis. So we will try medication if he is like very overweight. We will try some devices and may exercise. We will try a surgery if he has surgical indication for that, and then reduce costs. What's the risk benefits of with each therapy? And the long-term goals for the treatment will be the weight loss, always if patient is overweight, and then looking for adherence to the therapy. So if we start therapy as a chronic disease, we need to adhere with what's necessary for that. And for patients who drive, as we see, it's shown a high increase of traffic accident related to sleepiness. we need to be aware of those cases as well. And if needed, go through the latest test to measure the daytime sleepiness better. So thanks for your attention. Do you have any questions for me? Feel free to open the mic. Wait, if not, I would just ask you
Yeah,
to...
Tony has one. Go ahead, Tony.
Hi, thank you so much for your presentation and overview for an area that impacts millions around the world. I had no idea the impact. Can you please share a little bit more about the options or the recommended next course of action if CPAP can't be tolerated? And what is the uh, effectiveness of the exercises, for example?
Yeah, no, that's a great question. For each therapy depends on the phenotype, which basically means like what's causing your sleep apnea. So specifically for the exercise, usually if you have a moderate to severe sleep apnea, if you are overweight, it probably won't have effect. The study shows reduction in AHI, but it's limited number of studies. We cannot take conclusions on that alone, but you can definitely try. And also as an adjuvant. So sometimes you can do CPAP and the exercise. But it does show reduction in AHI when you comply with those therapies. But again, there is a protocol. I'll be happy to share with you some papers as well and how to do those exercise, the positions, the frequency, like every day, the sentences. So, but I would say it's more like as an adjuvant. I haven't seen a patient with severe or moderate sleep apnea that get well with the exercise only. So again, maybe the primary snorers, which is AHI lower, and the mild, they might benefit better of that. And sometimes as well, we want to treat the disease to give it, lessen the disease burden. So if patient can normalize the EHI, that's amazing. Some of them doesn't normalize, but they have a significant reduction on the EHI, and they go to the mild range with a CPAP, for example. And then I see a real benefit in going through advice, like exercise and adjuvant therapies. So there is not a right or wrong yes or no answer for all of the therapies. But when you say about, okay, next step for CPAP intolerance, we should discuss with the doctor what your sleep study shows. If it is a very positional sleep apnea, so you only have apneic episodes in your supine sleep, then you avoid supine sleep with positional therapy. So it's really looking at the results of each patient to see what the next steps are. And if multiple patients that comes to surgery, they want a more definitive measurement, that again, we cannot promise it could be definitive, but then we can try surgeries according to if there is an indication for that, according to the anatomy, to have a more sustained effect and see if you will be able to not use CPAP or not. Some cases you need some sort of, because you have a residual EHI. So yeah, there is not a workflow for that OSA management, but we do have all those therapies, and many more studies are needed to really show the effectiveness. So those studies that show they have seen EHI reduction. But we see nowadays that EHI is not the only thing that we have to look for. The hypoxemia burden has more, the hypoxemic burden in general. So desaturation, oxygen levels going low has more association with the disease endpoints. And the oxygen levels that is being dropped during the sleep sets are not being very correlated with the EHI. So EHI is frequent. Sometimes you can have multiple episodes, but they don't desaturate that much. So they overall, the hypoxemia of that night was not that bad. But other patients can have fewer frequency of episodes that desaturate a lot. So then overall in that night, they were a lot more hypoxemic, and they will have more disease burden. So I hope I give you some picture, but I don't expect I answer fully. Yeah. question. That's not
Very
right.
helpful. Thank you.
Yeah.
So I'll just, Ativ, I think I don't know if you accidentally sent it to me direct message, but asked, is there a chance CPAP can cure apnea?
No. If CPAP can cure apnea, that's a very, I would say, common thing to think, but we don't have a cure for sleep apnea. If you stop using CPAP, if you become non-compliant, you can return with the adverse events of sleep apnea. But if you are compliant, you do have a real benefit. So the studies, they show the most effective therapy when you talk about effective, it's CPAP so far. But yeah, that concept will also be challenged in the future. We are seeing different profiles of who respond to CPAP or not. This is very initial data. We are not still CPAP is the gold standard, but it doesn't cure. It will manage because it doesn't treat the root cause. That is the underlying mechanism that's leading to the area obstruction. So it's not treating the central regulation of the sleep. It's not treating the tone of the muscles. It's not treating the anatomic deformities. It's just giving you air with pressure, and that pressure is being higher to the point of opening that airway that is collapsed. So if the muscle is flexible, the pressure is able to overcome that. That's what CPAP does, but it's not able to cure. Anyway, I hope I have answered your question.
Really important topic. Like Tony said, this affects a lot of people, and why research continues to be a really important endeavor that you're a part of, Elaine, to learn more and to help treat people and prevent complications. So appreciate your presentation, putting this together for us. The recording will be available on the SCCR website, and you'll log in using your SUNET ID to watch it again. I'll also be sending an email with the course evaluation after the class today, and the PDF of Elaine's slides. So I encourage you to contact Elaine if you have other questions. I'm sure she'd be happy to answer them. And thanks for your attention again today. Please reach out if you have any questions. I would just like to point out that Chris Jamero, who I work with in SCCR, is going to be answering any questions moving forward for many of the education and training programs and courses and initiatives that we run within SCCR. My last day at Stanford is tomorrow. So just wanted to say thanks to you all who attended today and for your attention and joining the many things that we have done over the years together. So appreciate you guys, and please let us know if you have other ideas or topics for future science series or GCP topics in the Qualtrics survey link that I'll be sending out today. And let me know if there are any questions, and we'll give you guys back 5 minutes. And Elaine, thanks again for joining today. And you guys have a great rest of your Thursday.
Thank you.